sir. 79-year-old female admitted on 22 April 2022. Complaints of fever for 4 days, altered sensorium for 4 days, involuntary movements for 2 days, and loss of consciousness since 1 day.
Okay. So
She developed
what do you make out of this case?
Fever, altered sensorium, involuntary movement, and loss of consciousness. Mostly, it may be a case of meningoencephalitis.
Meningoencephalitis, brain abscess, cerebral malaria.
Yes, sir. Cerebral malaria.
Optical venous thrombosis.
Yes, sir.
Okay, so there are some possibilities are there. Okay, please go on.
Yes, sir. Developed an insidious onset, low-grade continuous fever without chills or rigor, subsiding with medication. Fever persisting through the course of illness, being present on most of the days. One episode of vomiting without nausea containing food particles. On the same day the fever developed, son noticed a difference in personality of the patient. Daily routine affected, skipping morning exercise, staring look, change food preference, speaking incoherently, and at times engaging in conversation with herself.
Okay, so somebody is talking to herself, engaging in conversation with herself. What do you make out?
Some frontal lobe is being affected, sir.
Possibly she is having some auditory hallucinations.
Yes, sir.
To which she is replying.
Okay, sir.
So which lobe is possibly involved?
Temporal lobe is being.
That's correct. That's correct. Okay.
Temporal lobe is being.
That's correct. Carry on.
Taken to nearby hospital. Next day developed involuntary tapping of the right hand on the bed with right leg movement. Event lasted for 15 minutes. Patient being conscious throughout the event. Lip smacking plus during and after the event. While being transported here, sensorium worsened. Patient responds to call and taps with moans. Developed a loss of consciousness as she reached our casualty. Lasted for a few minutes, after which she was unresponsiveness but kept her eyes open. Patient was on admission, kept in ICU on ventilator support, preferably moved right side of the body and persistently looked towards the left side.
So what are the possibilities that comes to your mind?
Sir, involuntary movements, there can be focal seizure, sir, on right side.
That's right.
With
lip smacking.
I think it can be aura, sir, of
lip smacking, auditory hallucinations are all common with focus coming from temporal lobe.
Yes, sir.
And then she possibly had generalized tonic-clonic seizures.
Yes, sir.
So then what happens is she is looking only to the left side.
Right side of the body, sir.
Left side of the body. So what is possibly happening? Right hand and right foot was moving to start with.
Sir. Because that is affection of the eye field, sir, frontal eye field. So neglect.
So possibly it was an irritative lesion on the right side.
Right side of the body, sir. Right side of the brain.
That's right. So possibly that something is happening. There's a conjugate deviation to left side. Either left side is paralyzed,
or it may be
lesion on the right side.
False localized.
So is it also possible that this patient has got a focus of seizure activity on the right side?
Yes, sir.
No, status epileptic slide picture.
Yes, sir.
So if this focus is from the temporal lobe, how does a seizure activity come from temporal lobe behave usually? You can take three patterns. One is at a focal seizure which patient is fully aware.
Focal seizure with intact awareness or impaired awareness.
So that was what possibly started here. And then she got the next stage.
Secondary generalized.
Impaired awareness. So possibly it was the second type of seizure from temporal lobe. Focal impaired awareness type of seizure.
Yes, sir.
And the third type is focal with bilateral generalized seizure. So
yes, sir. Yes, sir.
This is the, okay. So carry on.
Past history, there is no history of comorbidities like diabetes, hypertension, dyslipidemia, old PTB, coronary artery disease. There is a history of lumbar spondylosis, 30 years, not on regular medication.
So with this background, the fever as the dominant symptom, the headache is a problem. What may be the possibility, as you rightly said, maybe a encephalitis.
Temporal. Sir, HSV encephalitis, sir. Temporal.
Go ahead.
Consumes non-vegetarian diet, increased daytime sleepiness more towards the evening hours, no history of addiction, menopause at the age of 38, history of regular cycles with hypomenorrhea, hirsutism present, mother of 4, normal vaginal delivery. General examination, GCS E4 V2 M6, patient moves all 4 limbs, no pallor, ictra, cyanosis, clubbing, lymphadenopathy, there is or edema, hyperpigmentation of the palms present, hirsutism present, no rashes or vesicles noted over the body.
You wanted to state the possibility of a herpes simplex encephalitis. So here there are no rashes or vesicles.
No rash or vesicles. Pulse rate was 86 per minute, regular, normal volume and character, no radiofemoral delay. All peripheral pulsations checked present, bilaterally equal. BP was 100/60, temperature 99 °F, respiratory rate of 21. Nervous system, E4 V2 M6, patient is drowsy but arousable, glabellar tap present, out reflex present. Cranial nerve examination, 1 could not be tested, 2 pupil equal and reacting to light, bilateral pseudophakia present, left gaze preference present, direct and indirect light reflex present, 7, 9 and 10 within normal limits. Normal bulk and tone, positive movements of upper limb more than lower limb. Bicep, all the reflexes, biceps, triceps and supinator 1+, knee and ankle jerk absent, bilateral plantar flexor. Sensory and cerebellar signs could not be tested. Neck stiffness present, Koenig sign and Budinsky sign negative. Respiratory system, breath sounds heard bilaterally equal, crackles heard over right infraaxillary and infrascapular areas and left infrascapular area. Cardiovascular system, S1 S2 present, no murmur. Gastrointestinal system soft, no hepatosplenomegaly and bowel sound present.
So
sir, positive findings includes that frontal release signs, primitive reflex are being there, sir, glabellar tap and snout reflex.
These primitive reflexes are basically soft signs based upon which we need not diagnose.
We can diagnose.
But the important thing is your patient has neck stiffness.
Neck stiffness presence.
Persistent gaze to one side, and she is having altered sensorium.
Yes, sir.
So, as you rightly said, it may be meningoencephalitis.
Meningoencephalitis or maybe some abscess, cerebral abscess can cause.
Possible. And in considering the pattern, temporal lobe is possibly affected.
Yes, sir.
And she was having persistent eagerness of the eyes. It may be close non-convulsive status.
Status epilepticus. Also aspiration, because crackles are there, aspiration pneumonitis also.
Okay. Then we go to investigations. You need not read everything. What is given? The red color is the important one.
Total counts were raised initially of around 17,000.
Then it came down to normal subsequently. So what other investigation do you want in this case?
Lumbar puncture has to be done, sir.
Yes, it is here.
With normal protein, normal sugars.
White cell count is 20.
Lymphocyte predominant, sir.
Lymphocyte predominant. RBCs are present.
RBCs are also present, sir.
So what do you do next?
Radiological investigation. Peripheral smears.
So she is anemic, so that also not worry. So
okay,
as you rightly said, we want imaging. Imaging was done.
There is left medial temporal lobe appears mildly enlarged and shows altered signal intensity on T2 flare with no evidence of any diffusion restriction, with prominent ventricles and T2 flare intensity noted in the periventricular region, suggestive of small vessel ischemic changes.
Here is the temporal lobe for you.
Yes, sir.
Okay. Then we go ahead. What else you want?
EEG has to be.
Okay. In view of the persistent conjugate deviation, as non-convergent is indicated.
Yes, sir. Interpretation shows a periodic epileptiform discharges arising from the left cerebral hemisphere, predominantly left temporal.
So, and what next you want?
HSV, because with the EEG pattern more towards the temporal region, we have to go for HSV, sir. HSV DNA.
So, is also
positive, sir. HSV
what?
DNA.
One.
HSV1, sir. HSV1.
One is positive, two is not positive.
Yes, sir.
No. Is there a difference between HSV1 and 2?
It's there, sir, but I could not recollect.
HSV2 classically presents global encephalitis.
Okay, sir.
HSV1 may be focal.
Okay, sir.
Okay.
Yes, sir.
So diagnosis?
HSV1 encephalitis.
Encephalitis. Now, among the different types of viruses producing encephalitis, is there a predilection for different parts of the body?
This HSV1 has temporal predilection, sir.
Yes, any other? No. So she was continuously having this persistent conjugate deviation and seizure-like activity. She was unconscious.
Okay.
So what do you think? Status epilepticus.
Yes, sir. With the secondary generalization status epilepticus, sir.
So how do you define that?
Any seizure activity that is recurrent seizures without regaining of consciousness in between, or a seizure activity continuing for more than 30 minutes.
Okay. Okay. So
okay, sir. AC.
Non-convulsive type of status epilepticus. No.
Okay, sir. Convulsive and the non-convulsive.
So depending upon the virus, different areas are affected.
Okay, sir.
So chickenpox affects which part of the brain predominantly? The universal, but
cerebellum, sir. Acute cerebellitis.
And this Nipah virus?
Nipah will be causing subcortex and deep white matter.
Rabies?
Rabies.
Hippocampus?
Will cause hippocampus.
Basal ganglia, thalamus, and midbrain.
Okay, sir.
And HSV predominantly affects the medial inferior temporal
lobes. Okay, sir.
So there are some differences among the different types of viruses. So HSV encephalitis, is it type 1 or type 2? HS1 or 2?
1, sir.
1. Okay. 1 is okay. Coming to the viral meningitis, what is the pattern like?
More predominant in enterovirus, sir.
Enterovirus, okay. Then?
Followed by HSV2, then HSV1 and varicella zoster.
So HSV1 is predominantly encephalitis pattern, right?
Yes, sir. Meningitis pattern is more for HSV2, sir.
Okay, right. So what are the usual clinical features you have?
Fever with cortical involvement. Because of that, there will be personality changes, headache, disorientation, memory disturbances, motor laxity.
Almost all of these features, no?
Yes, sir. Yes, sir.
So how will you proceed to treat this patient?
We will be going for antiviral, sir. Acyclovir, sir.
What is the outlook like?
Sir?
What is the prognosis like?
Prognosis is good with patient will improve with IV acyclovir, sir.
Looking at the CSF, is there a clue to the possibility of a HSV infection?
Lymphocytic predominance was there, sir.
That is common for all viruses.
Yes.
And presence of RBCs.
Yes, okay, sir.
Okay, so RBC is possibly RBC was 9.
Okay.
When the RBC 9, so that is possibly a clue.
Okay, sir.
Okay, so EEG was supportive, MRI was supportive, and these are the three investigations commonly we do for HSV infection, and all the three have come positive for
Okay,
our
sir.
particular case. And
Okay, sir.
MRI changes are classically seen in number low. Again,
Yes,
we have got that pattern. So coming to mortality, what's mortality like?
It includes several factors, sir. The level of consciousness at the initiation of therapy, patient age and duration of disease before therapy, sir.
This is a senior citizen coming up, and she was treated with a cyclovir, so she must come
Okay.
into the better category of the persons. And
Okay,
do you
sir.
expect full recovery or residual defects are seen?
Residual defects most will be seen, sir, because her GCS was being poor at the time of initiation, and also
That's
maybe
correct. Very good, very good. So
okay also because of the age of the patient, maybe.
that's right. That's right. But this particular patient improved quite a bit. She's not absolutely normal, but she walks around, talks, although not usual self.
Okay, sir.
Okay.
Okay, sir.
So do you give steroids?
Steroids.
There are some studies showing that the steroids may help to reduce cerebral edema.
Cerebral edema. Okay, sir.
And alternate drug for virus,
Valcyclovir foscarnet, sir.
foscarnet can be given. So what will be long-term outlook for these patients? Some of them will come back with immune-mediated encephalitis. It may look like a relapse of the case.
Okay, sir.
But majority of the time they are monophasic. There's one episode, and the return of features of relapse is usually immune-mediated if at all.
Okay, sir.
Some differences are there in the presentation between children and adults, but basically we hope this patient will get well.
Okay, sir.
Okay, so
Okay,
how many cases you have seen of simplex encephalitis?
Sir, I have seen one case 2 weeks back, sir. But that patient was having vesicles over their face, sir. So it was easy to
Easy to diagnose.
for.
Okay.
Yes, sir. Yes, sir.
This patient was not showing any such thing, so we could not. How does this virus enter the brain?
Sir, through nasal route.
That's right. Through the nasal route, trigeminal nerve it goes through. And
Yes, sir.
if the patient's GCH is 9 to 15 and they present within 24 hours, and if they present before loss of consciousness, prognosis is said to be excellent.
High excellence, sir.
Excellent. But your patient came a bit late, GCH was a bit
Late
low.
person. Poor GCS, sir.
So it's a poor, but still she came out to a certain extent.